502. Good afternoon, and on behalf of the committee, the Joint Select Committee on Social Services and Public Administration, I'd like to welcome you all to the third town hall meeting of the JSC on Social Services and Public Administration on public healthcare services in Trinidad and Tobago. We are pleased to be coming to you live from the Southern Hall at the Centerpoint Mall in Chaguanas. Members of the viewing and listening public are invited to submit their comments on the Parliament's social media platforms, YouTube channel, ParlView, or Facebook and Twitter. At this time, I'd like to introduce you to the committee's members, starting on my left.
A pleasant good evening, everyone. Vandana Mohit, member for Chaguanas East and member of this JSC committee.
Good morning, all, and welcome to the beautiful borough of Chaguanas. I am Avinash Singh, a member of this committee.
We will be joined in process by member Esmond Ford and member David Nakit, who are on their way. We'd also like to acknowledge the presence of Dr. Abdul Hamid, who is a primary care physician too, who will be giving us an overview on NCDs in Trinidad and Tobago. At this time, I'd like to advise you on the purpose for these town hall meetings, which we have embarked on. This town hall meeting is being held to provide the public, citizens, you, the taxpayers, with a platform to directly engage members of Parliament, your representatives, on some of the critical issues concerning the delivery of public healthcare services in the country. This is an opportunity for you to share your experiences having interacted with the public healthcare system at one time or another, or in the company of a family member or relative. We'd also like you to make recommendations for improving the public healthcare system based on your experiences. Now, healthcare is a very broad and multifaceted area, so the committee has narrowed its focus to these three main areas: combating non-communicable diseases, NCDs, in this case, diabetes, cardiological diseases, and cancer, three very prevalent diseases in Trinidad and Tobago and indeed around the world. 2, the effectiveness of the Chronic Disease Assistance Program that you may know as CDAP. And 3, to look at the standard of service at outpatient clinics in the country. On November 15th, 2023, the committee met with the management team of the Ministry of Health and the regional health authorities to discuss the state's strategies for combating non-communicable diseases, NCDs. Since then, the committee has embarked on these town hall meetings. We've had 2 so far, the first at the Parliamentary Complex in Port of Spain, the second on the 29th of, let me just make sure, November at San Fernando City Hall, Corporation Auditorium. I'm sorry, that's on Thursday, January 18th. The first one was on November 29th in Port of Spain. And of course, this one here today in Chaguanas. We plan to do one more coming up so we cover the entire breadth of the country. Now, the committee is empowered to do specific things, but it's not empowered in this case to do some things. I just want to clarify what we can and what we cannot do so you're clear on our remit and our responsibility. The committee is not empowered to provide redress or remedies to individual complaints. So I know some of you may have ailments or issues. We're not here to diagnose or provide advice on those, right? We do have the power, however, to hold the Ministry of Health and those who manage public hospitals, RHAs, accountable for their performance, their policies and their procedures, their programs and initiatives in their interface with you. We are one of 14 committees of Parliament appointed to scrutinize or oversee certain aspects of work of the government of Trinidad and Tobago. The committee's work is not dictated by any political party or any political agenda. The mandate of this committee includes investigating and reporting on all matters related to the management, activities, and administration and operations of various state bodies with a focus on education, gender issues, tourism, public administration, labor issues, culture, community development, other social services, and of course, health. At the end of this inquiry, the committee will submit a report, compile and submit a report to the Parliament of Trinidad and Tobago containing its findings, your feedback, and recommendations, which will be sent to the Health Ministry and the RHAs for their attention and their responses. We'd like to at this time acknowledge some stakeholders who've taken the time to be with us here today, and these include the Trinidad Tobago Association of Retired Persons, the Geriatric Society of Trinidad and Tobago, the Diabetes Association of Trinidad and Tobago, the Trinidad Tobago Registered Nursing Association, the Trinidad and Tobago Residential Care Association, the Trinidad and Tobago Medical Association, and the Trinidad and Tobago Cancer Society. We appreciate you taking the time to be with us today. At this time, as we've done with our first two public engagements, we'd like to hand you over to a medical healthcare professional with the RHAs to give you an overview on the subject matter today, which is NCDs. Please join me in welcoming Dr. Abdul Hamid, who is a primary care physician too. Dr. Hamid.
Good afternoon, everyone. Thank you, Dr. Richards. So I'm very happy to be here today. My purpose really this evening is to probably have some sort of change in the way we think about NCDs in Trinidad and Tobago. So as you know, NCDs, or some of you may know what NCDs are, they are non-communicable diseases. And what I'm going to do is give us some objectives. What are some of the causes of NCDs? What are the prevalence rates and risk factors of NCDs? And what are the principles and approaches to dealing with NCDs? So basically, we're going to see how bad the situation is first, and then we will have the solution. I will give you all the solutions that we'll have to take forward. So what are some of the examples of NCDs? Some of you may know, but some may be surprised. So there are heart disease, diabetes, cancers, stroke, chronic respiratory diseases such as asthma, COPD, chronic obstructive pulmonary disease, and mental health issues such as depression. What causes NCDs? So what we have is a high and increasing prevalence of risk factors in the population. And we class those risk factors into modifiable and non-modifiable. Non-modifiable risk factors. Unable to modify age, you are unable to modify genetic factors. But what are the modifiable risk factors? Now, these are the risk factors that we have to focus on as a population. And these are things that are what you call small ticket items, basically, things that people can take on their personal volition to change. These are tobacco use, alcohol abuse, unhealthy diets, obesity, and physical inactivity. Moving on, we have high blood pressure, high cholesterol, and raised blood glucose. Moving to tobacco use in Trinidad and Tobago, and these are from studies and so on that would have been done nationally. About 21% of our population currently smoke, and the average age of initiation of smoking is around 17 years. And that's a fairly frightening statistic for us here in Trinidad and Tobago, considering what are the dangers of tobacco use. Unhealthy diets in Trinidad and Tobago. And this is surprising considering we started off as a nation with an agricultural background. The diet of the population is deficient in fruits and vegetables. Our diet currently is based on oils, carbohydrates, and sugar, especially the overuse of sugar-sweetened beverages. And I'm sure on a daily basis, when you go around on the streets, you'd see these large trucks full of sugar-sweetened beverages all over the place as if it's given away free. Alcohol consumption, Trinidad and Tobago, 40% of the population are current drinkers. And concerning statistic, 86.5% of 13 to 15-year-olds had a first alcoholic drink before the age of 14 years. Physical activity, Trinidad and Tobago. As we know, we are now in the age of the digital era, and we have increased sedentary lifestyles, especially starting from childhood. And basically, it's a battle to get children to come off of screen time and do anything physical. 30 years ago, when we didn't have any devices or so, the children used to be flooding the playfields, the schoolyards, the yards, the rural streets, and so on. Now everybody's indoors on a tablet, on a device. Overweight and obesity. This is something we should not be proud of. 55.7% of the population, 15 to 64 years old, are overweight or obese. And that's another scary statistic. But, as I said, we can't change this. Hypertension, Trinidad and Tobago. Of the adult population, which looking at approximately 1 million persons, 26.3% of the population has elevated blood pressure. We could round that off to about 30%. And that means we have 300,000 people right now in this country walking around with high blood pressure. Even when we have large-scale public screening activities, that goes up to approximately 50%. And of those 300,000 persons, only half of those persons know that they have high blood pressure and are being treated or are taking treatments or are doing something proactive with it. So we have walking around everywhere. We have tens of thousands of people who don't know their status. And that is something that we as a nation, we need to fix. What are the consequences of hypertension? And it's no stranger to some of us. It's one of the main risk factors for premature cardiovascular events, and is the second cause of disability in the world. It's also the main cause of ischemic heart disease and stroke. And no stranger to the rest of the world, 36% of cardiovascular disease deaths occur in people under 70 years of age. And what we see now in the public health system is younger and younger and younger persons showing up in the emergency departments with fatal heart attacks, with strokes, unable to survive very long as well. Elevated blood glucose. Prevalence of elevated blood glucose is approximately 20.5%, which equates roughly to about 200,000 persons with elevated blood glucose. And that also includes persons who are diabetic and persons who are what you call pre-diabetic. I know there's a busy slide, lots of words, but basically, diabetics has a twofold increased risk of stroke, lower limb amputations, 10 times more common in people with diabetes. It's a leading cause of visual impairment and blindness in developed countries. And persons with diabetes require at least 2 to 3 times the healthcare resources compared to persons without diabetes. Mortality and morbidity due to NCDs, and this is local data. 25% of deaths, heart disease, 14% diabetes, cerebral vascular disease, 10%. 70% of ages or deaths occurred before the age 70. And most important takeaway from this, 4 out of 10 could be prevented, as they all share some type of modifiable risk factors, as I would have mentioned before. And as mentioned before, heart disease is absolutely the leading cause of death in Trinidad and Tobago. And ischemic heart disease is responsible for the majority of premature deaths, especially in the 30 to 60 years age group. That 30, that's a scary age to have that situation happening. Cancer. TNT has one of the highest cancer mortality rates in the Caribbean, and is most commonly due to late detection, persons showing up too late to get themselves screened, to get themselves checked. For men, prostate cancer is most prevalent. For women, breast cancer, quickly followed by cervical cancer. Diabetes. So TNT in the Caribbean ranks among the countries with the most prevalent and fastest growing cases of diabetes. 50% of diabetic deaths occur before the age of 65. And diabetic retinopathy is the leading cause of adult blindness in Trinidad and Tobago. So finally, how are we going to fix this problem? And we have a few principles and approaches that, if it is something that we take away from this lecture here today. So it is a multi-sectoral action involving all of society. We have sports, agriculture. We looking at more health promotion with a focus of prevention. So our population right now is focused on getting diagnosed and treatment, whereas we need to look in the direction of prevention rather than getting a diagnosis first. We need to recognize that NCDs are an existential threat to the family and the population of Trinidad and Tobago. Our approach should be a wellness approach in terms of persons taking ownership of their wellness, taking personal ownership of their health, not waiting for something to happen, then to be reactive about it. Because we feel well all the time, but when we get sick, it's a terrifying moment for everyone. We need to have a proactive individual approach to deal with this problem. We need to have early detection and control of your NCDs. Some of these screening events that we have persons who come in, they do their blood pressure, it's shockingly high. Then they tell us, oh, well, 10 years ago, I did blood pressure and it was high. I took some tablets for a couple of weeks, I felt better. And after 10 years later, the NCD doesn't go away. That's why I call it non-communicable disease, chronic diseases. It does not go away. A lot of persons think that they take some tablets and they get cured of diabetes, they get cured of hypertension. It doesn't go away. You have to work very hard to keep it under control. And finally, primary health care, prevention focus, and integrated management for patients who do have NCDs. Thank you very much.
Let's show appreciation for Dr. Abdul Hamid, primary care physician 2, who gave us an overview of the NCD situation in Trinidad and Tobago. And I don't know how many of you were as shocked as me, and I've seen this data before. By a show of hands, how many of you were surprised by what you saw there? You weren't surprised? You knew this was happening in Trinidad and Tobago? This is astounding. So what I got, and I'd like to acknowledge the attendance of Member Ford. Thank you, Member Ford, for coming. is that a lot of what is happening with the health of the nation is in our hands. But we don't see it that way. We wait until we get ill. We don't take preventative measures. Our diets are an issue, and our sedentary lifestyles are an issue. And the reluctance of primarily men to seek medical intervention, because we're supposed to be tough and bad, is one of the issues that leads to the exacerbation of the situation and the drain on the healthcare system. So one of the things that I've learned in these interfaces and in looking at the data, not only in Trinidad and Tobago, but around the world, is that a country cannot spend its way out of this. You could put $10 billion, $15 billion, $20 billion. If the population doesn't get the message about prevention and taking decisions in your life and your family's life to make sure that you are healthy as possible, and if you will get sick, you go and get an early detection and management of it, the country will have to spend more and more and more, and it's more and more heartache for you and your family. So a lot of this is in your hands, and part of the reason we're here is also to educate and inform the public on what is the best way forward for all of us in Trinidad and Tobago. So we're going into the Q&As now and giving you, as I said before, chances to interface and tell us about your experiences in the 5 broad areas. We will go area by area, and as I indicated before also, you can contribute on more than one area. You can contribute in all 5 areas if you've had issues with those, and it's not limited to only criticism. If you've had good experiences, you share those with us also, because we want to be as open and objective as possible, right? If you have a question or a comment, you simply make your way to the microphone, which is placed in the center of the room, and identify yourself if you so desire, and give as brief as possible a contribution. We'll appreciate if you're representing an organization to state the name of the organization. We ask that you keep your contributions respectful, avoid using any insulting or obscene language, and as concise as possible. At this time, I'd like to pass the microphone over to Member Vandana Mohit, who will focus on the first area, which is governance and management of the public healthcare system. Member Mohit.
Thank you very much, Chairman. And before I go into questioning, I would like to take this opportunity to say thank you to each and every one of you for making the effort to be here this evening to contribute to this JSC. I'm sure it will go a long way in terms of us reporting. As we begin the question and answer, I'm looking at government and management of the public healthcare system. And the big question is, are you satisfied with the current governance and management of the public healthcare system in Trinidad and Tobago? There are 5 RHAs, and what are the main weaknesses of the RHAs which you may have had to have an experience with, the extent to which the management of the RHAs have been able to transform the quality of healthcare received at public hospitals. And in terms of your questioning, the relevance and impact of policies developed by the Ministry of Health. For instance, opening times, closing times, and accessibility. All of these fall under governance and management, so if you have any questions. And lastly, how would you describe your most recent experience visiting a public healthcare facility? What were the good or positive aspects, or what were the negative aspects? So we now open the floor for you to give your experiences or even share recommendations.
Gentleman in front. And just raise your hand and I'll direct you to the microphone one by one in order that you raise your hand, please. Thank you.
Thank you, Dr. Richards. Chairman, I want to make mention of 2 aspects of the facilities in respect to the health sector. My view, I have visited a couple on my own. They have been, in many cases, underutilized. And I want you to take a note of that, because you have health centers finish at 4 o'clock, and you have the community still alive and active, the villages. And many instances, you have to go to Hoover, let's talk about Central, or you may have to go to Montrose. Now Montrose has been moved to Ramsaran Street. But there are buildings could be maximized and utilized to its fullest 24 hours, because people don't get sick 4 o'clock in the morning or 6 o'clock in the evening. There's a time for them to get sick. People get sick anytime. I believe the government, the health sector is paramount for the country, for the people, and therefore the facilities must be maximized in utilization. And to do that, I want to suggest staffing of these facilities are paramount and very important, because, and not only staffing, but experience, expertise of people in the field of what you have just outlined, Dr. Hamid, those areas. So when people come, you don't have to buff them up and ask them this and that. You would know. Because these people, some of them are old, they lost their memory, they're losing their memories. Dementia is prevalent, and all of these must take into account. There are this morning I visited a building in Cuba. You are asking people from Cuba social facilities to come to Chaguanas. And you have a building there, has not been utilized since last year. Those are, it's all tied in with the health factor and the social benefits and so on. I want you to broaden your scope a little bit in the area of the social factor in respect of people getting their pensions and all these kind of things, because people are not looking at these. They look simple, but they are areas of serious concern. But again, going back to the medical facilities, there are buildings that Caroni left when Caroni closed down, can be utilized. And there were clinics in these areas that have been operational. And to lighten the volume of the workload in these other areas have to be considered very serious and to address. That is what I have to say, but it's something you need to look into immediately.
Thank you so much. Ma'am?
Good evening, everyone. My name is Ramraji Prabhu. I'm a singer, entertainer, national icon in the spheres of culture. Right. And also known as the chutney queen of the world. Right? So, you know, being an entertainer, everything is about singing for me. So I want to sing a song for you all here this evening. And I'm quite confident that this will make an impact in everyone's mind. Unity is power. If we have unity, we have everything. When we were born, we were so innocent. We knew nothing about racialism. Times gone by, love was the answer. My brothers and sisters, let's come together. So let's live in unity here in TNT. Our beautiful country is for you and me. We need a new direction for our future generation, for the youths who have gone astray. They must now put down the gun. Unity is power that will break the barriers so that they will understand we are all human. So let's live in, everybody, unity here in TNT. Our beautiful country is for you and me. United we stand and divided we fall, bringing people together, that should be our call. Respect for people's position, and always remember that someday in future your son or daughter could be the Prime Minister. So when we were born, we were so innocent. We knew nothing about racialism. So let's live in unity here in TNT, our beautiful country. Look how they unite in there. Isn't that beautiful? Look how you all
Let's
unite
give her a round of
here.
applause, please.
Thank you very much.
Thank you so much.
Thank you.
Thank you.
And also, I am qualified in the medical field through my cultural profession. I'm graduated as a medical assistant with ECG technician, phlebotomy, and also I'm a certified home health aide in 5 different areas, all complements United States and my culture and my government. I want to thank every one of you. God bless you, and have a blessed evening. I have to leave for another event.
Thank you
God
so much.
bless you.
Well,
And if you want my song, and you like that song, I have the entire song. I
I'm
will
going to have
give
to
that
stop
to the
you
nation.
because this is an advertisement now.
Right.
But thank you very much. We're not going to refuse any entertainment. Thank you. Sir? That's why I love Trinidad and Tobago. Thank you, Member Naked.
Good afternoon, everyone. My name is Devanan Sridat, and I want to raise a few points here. First being, I would like to know what is the standard operating procedure for when a person gets a heart attack and is taken to the hospital.
You asking what is the standard operating procedure when someone has a heart attack and is staying or is warded at the hospital?
Yeah, they go to an emergency clinic and they are then transferred to the hospital. When they reach the hospital, I would like to know what is the procedure there.
Well, it would depend. We can't answer that for you with the greatest of respect because we're not qualified to answer that, right?
I know that.
Yeah.
But I would like the committee to
please. In terms of the report, we'll try to include it so you get a sense of it from the report when we complete it.
The second issue I want to raise is the question of dispensing of medication. You go every month to collect medication at Mount Hope, or I don't know if all the regional health authorities is the same, but I could talk about Mount Hope where I have to go. And in the beginning, they would have taken the prescription, they would attach a number to it, and you would sit down and wait for your name to be called. Now that procedure has changed. They're giving you, when you go, they take the prescription, they put a number on it, they hand you back the prescription, and you go and you sit down and wait until whatever time that number calls. Then they will take it. You go back and sit down and wait till whenever they get the medication, and they would call you to collect it. So sometimes you're there sitting for at least 2.5 to 3 hours waiting for medication. And that is the good part. The bad part is when they bring the medication for you, you do not get all. You now have to run to different health centers to see if you could get. In my case, I go to Napuna, I go Tacarigua, I go St. Helena, I go Cunupia, I come here, Shogwanas, Freeport. Last month was the first month that I was able to get all the medication in 3 years. First time.
And what you're saying is that if your prescription has more than one item on it, you have to go to various health centers to get each of the different ones filled.
Because if they don't have it in Mount Hope, the prescription is then stamped and they tell you you could go to another facility to look, to see if you could get it. So now a person is not only sick, but is under stress because they have to be moving around hunting for medication. If you don't have transport, what is your situation?
And do they tell you where the medication, the specific item may be?
No.
But you have to go and find out yourself.
Yes. That's why you have to go to all these different health centers.
And there's no guarantee when you go to the other one?
No, that is why you have to cover so many different places.
How long has this been happening now with you?
That's the norm.
That's the norm.
That's the norm.
In your ill state.
Old people, sick people, you literally see them struggling.
And when you go back for your assessment, do you get a sense from the medical healthcare professional, what is the input? Let's just say for conversation's sake, you have 5 different medications on the prescription, and you get 3, and you don't get 2, but there's a reason that you were prescribed 5. Do you get a sense, a conversation with the medical healthcare professional about the impact of not taking all 5, so you know what's happening to you?
I think you rushed me a little bit there. Because I had surgery December. I saw the doctor in the beginning of January. And my next clinic appointment is in September 2025. So how could I speak to a doctor?
So just to be clear, you went when?
I had surgery in December. I had my clinic in January, beginning of January. And my next clinic appointment is in September 2025.
Would you care, and this is entirely up to you, is it an urgent situation? Are you satisfied with that time frame you were given for the next appointment?
But this has been going on all the time, sir. This is not something new. I got sick in 2021, spent 7 days in the hospital, was supposed to go to do surgery. The theater had some problem, and I was discharged. And
without the surgery?
Without the surgery, and the surgery was now done in December of last year. After 3 years.
So you waited 3 years for the surgery?
Yes.
And your next appointment is in 2025?
To see a doctor in the clinic.
And this is the follow-up to the surgery that you had after 3 years?
Yes.
Additional question. Your surgery that you received in December, was it based on an emergency or was it a date given to you?
No, it was heart. I got a heart attack in 2021.
It was a heart condition?
Yes.
I was trying not to ask your business, but wow.
When I say emergency, I'm asking, did you go into the emergency department?
Yes.
You checked in, and that's how you received your surgery, not
Yes.
another date?
No. They eventually called me in December, just before Christmas, and told me to come in to do the surgery.
I have one more question because I know other people want to contribute to this. So when you had your surgery, this appointment in 2025, is it at the general hospital or is it at a healthcare center?
It's at Mount Hope.
It's at Mount Hope?
Yes.
And had you asked your doctor if that could have been your assessment, because I'm assuming it's for an assessment post-operative?
Well, the doctor didn't make the appointment.
Who made the appointment?
Is the receptionist at the outside, yeah.
Okay, thank you. Thank you, sir.
So there is some disconnect in the management system of this whole thing. Because you have people who keep going over and over and over, getting an appointment for surgery, and they're still not getting the surgery. When they go, they are being rescheduled. Even clinic appointments, when you have a date for a clinic appointment and you go, it is rescheduled. This is the norm.
Even though you have an appointment in 2025, which is astounding to me, you have no guarantee that that appointment will be kept.
No.
Okay. Is there anything else you want to share with us?
I would hold it there for the time being because...
Thank you so much for your honesty. We appreciate your contribution.
Thank you.
Any other persons on this area? Ma'am.
Good afternoon, everyone.
Good afternoon.
My name is Brenda John. I'm the Councillor for Enterprise South Londonville North. I'm also the chairperson for Public Health for Shogunas Borough Corporation. I'm also for 30 years working in the public health in hospital. All right? What I'm hearing from the speakers, it is truth. And dealing with the public in hospital is something very dear to me, and I'm hoping that this panel could bring it to the Minister of Health, that we need to include the stakeholders, the workers in the hospital. They know the runnings as well, so when they're having these meetings, they don't get left out. First thing, the waiting time. When you enter casualty, that waiting time is too long. Yes, we have emergency in casualty. We know we have to prioritize. But when you put somebody to sit down there for 2 to 3 hours, hungry, nothing to eat, no one coming to communicate with them, what is happening with the elderly at the hospital at casualty? We have 5 RHAs, right? And you'll keep hearing people saying about Sandy Grande Hospital. Why is Sandy Grande Hospital at a certain level and the rest is not? So we could copy what Sandy Grande is doing and we could put it standardized throughout the rest of RHAs. So if we could work with Sandy Grande and see what's working for them, we could do the same with the other 4 RHAs. So what I'm saying with the non-communicable disease now and the policy, if we could have something starting from school, primary school level, because you know people like the soft drink, the sweetness, and that will add on with diabetes. If we could have something put in school to assist with this, because I looked on last week on the channel from Japan or China, what they're doing in the classroom at primary school level, they're having exercise before classes start. So if we could have the exercise and building up and the children moving, I think that will help them as well. We just have to educate them and let them know, yes, the fruits them is expensive, but we have to sacrifice. As you were saying, Mr. Chairman, it's them with us. So if we don't care for ourselves, who will care for us? We cannot wait for the government to do it. We have to have that within us, because I want to be healthy. I think everybody here wants to be healthy, but it's too expensive. The fastest thing is fast food. Easy access. Easy access is just now as KFC raise the price, we see in limited people there, but at the same time. So I'm asking if the panel, we could come together, formulate policy to help with the non-communicable disease, because it don't stem with the elderly alone, it stems from the youths. You'll see the age that the primary health care physician was saying was 17 years. 17 years is young. So they are not working, so how are they getting to eat these type of food? So at least if we could go into the schools, the hospital, walk through, you know, it have something called undercover, and we go into the hospital, sit down and watch how they operate with the clients at the hospital. It's something frightening. When you go to the pharmacy, you'll use a prescription, they don't have the medication. We could go up on the system, see where have the medication, and you tell the client, here, go to this medication, go here. Instead of they jumping from one place to the next, it's passage wasting. You're already under stress, traffic on the road, by the time you reach the place closed. So if we could better formulate that, I think it will work. So thank you.
Thank you so much. The lady in black wanted to make a contribution, and then the gentleman with the hat, please. And then we move on to our next overall topic.
Good afternoon.
Good afternoon.
Well, first of all, I'd like to just a couple of things that Dr. Hamid talked about. You talk about preventative, right? And you're talking about what we are doing to prevent getting to the stage where we have to get to the hospital. But I noticed that we only have these pre-testing things when there's special events, like Women's Day. You have all these things, all the checkups, because we come down a lot on women about how we do not get ourselves checked out. But we only have certain things available when there are events, International Women's Day, and then you have it only in certain locations and a certain amount of time. That's not gonna accommodate everybody. If you do these things, because let's be real, most people cannot afford the cost of pre-tests and things like that. Every little thing, I want to get my cholesterol check, is $180 to go into private. Everybody is catching their skin in this economy right now. And we're talking a lot about elderly, but we also could talk about from beginning to end, for everybody is in this situation, right? We ended up with people who have a lot of hypertension and all these kinds of stuff because of the stress that people are under. I mean, but that's something we will, when you all get to talking about depression and stuff like that, that I will also speak on that. I had an experience last week where I was in the hospital twice in last week alone. And I will say to you, first of all, speaking on what the gentleman was talking about in the pharmacy, I was discharged on Sunday at before 10 o'clock and did not get out of the hospital until after 12 o'clock, sitting down in the pharmacy. Now, you could imagine,
Which hospital was that?
Mount Hope.
Thank you.
Could you imagine that I was in there because they were checking to see if I had a heart condition, if I had some kind of heart, because I had an incident on pain on Saturday. I went with my bag packed because when I went on Monday, I went through I got a pain on Monday, went through Shagona's clinic, was transferred by ambulance to Mount Hope, sat down in Mount Hope, and they wanted me to stay. They wanted me to spend the night just so that I could get to see the senior cardiologist the next day, the next morning. So they wanted me to spend the night to see the senior cardiologist. I had not had anything to eat or drink because my family cannot come into emergency. I was in the same thing from 8 o'clock until 7 o'clock in the night. And that's with going through the health center with the ambulance. So when they talk about how long you stay, how long a heart patient, when the gentleman was asking, what is the procedure where that is concerned? That is the length of time where they were trying to figure out whether I had had a heart attack or not. From 8 o'clock in the morning till 7 o'clock in the night, right? And that's just the experience on Monday. On Saturday, I went with my bag pack. I went with a knapsack with water and snack and my bag pack just because I figured they're going to keep me again.
So did you tell any nurse or doctor that you had not had anything to eat or drink?
Yes, I told them.
And what was their response?
Well, nothing, because they said, well, the vending machine not working outside. They said, go try the vending machine.
So they directed you to go and buy something to eat and drink?
No. And, sorry? Okay, yeah, sorry about that. Yeah, just to give me a tablet, they had to go get water for me because I didn't even have water on me. And they came and they brought a tablet for me to take and I didn't have no water.
At Mount Hope? At
Mount Hope. Let's not even talk about on Sunday. I was in Mount Hope and there was no water in the whole hospital. Could not flush the toilets. They could not. They had 2 women in the ward with me in the room who were bedridden, and the nurse came and said, we don't have any water to clean you. I couldn't use the washroom because I had no water to flush. I was out of there like the speed and light, and I was so glad they tell me to go home. I pack up my stuff, and then with my patient van, go downstairs to go get the medication, the Hototoa medication they asked me to get in the pharmacy. And they still have not diagnosed that I have a problem. We don't know what the issue is, but they give me...
just guide me through this. So you have not had an official diagnosis yet?
No.
But you have a prescription?
I have a prescription with 1 Hototoa tablets. and then tell me to join the cardiac clinic, for which I don't have when I went to get the appointment, I don't have an appointment till June.
But had you had a full assessment by a doctor, the cardiologist yet?
No, all they did is they just did they did the ECG, the X-ray, and they did the test for heart attack, and all of that came back negative. So they don't know what the issue is, but they say, here, take all these tablets. Take all these tablets, and then when you come in June, we'll then assess you again, and then decide we want you to do an ECG and an echo and whatever, but then I don't even know when I get in that. So I have to go and borrow money from somebody to try to see if I could get these things done, because the issue is I can't wait, and then you put me on all this medication and I don't know what that's doing to me. Let's be honest, I don't know what that's doing to me. But the most important thing is that I am discharged, so I am down there with all these people in the pharmacy waiting for 2 hours. 2 hours. Just to see, and then people were quarreling because after all that wait, some people, when they reach to the pharmacist, then they tell them they don't have the medication. So after you wait 2 hours to find out that, guess what, they don't even have what you want.
Member Ford.
Tell me something, Miss, again.
Yeah?
Good afternoon, good evening to each and everyone.
Good afternoon.
Just to clarify, now we are here in order to be edified, to gather information and knowledge, in that we would be presenting a report so that we hope that action will take place, right? I'm sure the chairman would have made that clear. So again, is it that in emergency, once you're in the emergency, you would not be provided with no meals? Nothing. Right, that's clear.
The person passed by, and I don't want to lie, person passed by like hours after I'd been there. Remember, I'm from between the health center to come to Mount Hope, so I'm sitting down there from like lunchtime. The person just passed by and they just asked, okay, how long are you here? How long are you here? And then they give you...
So based on the length of time that you may be in emergency, then you may probably get
and no water, just that's just once that person passed in the evening time.
Okay, let me just put a pause. I know Dr. Hamid is here. Doctor, if you could, I know you're not here to diagnose anybody, but what should be the process in terms of intake? I know there's a triage situation involved where the most emergent cases are diagnosed and dealt with. Could you just give us an overview of what should happen? Thank you.
Thanks, Chair. So basically, once a person has symptoms that they are experiencing suspicious of a myocardial infarction, so you would have gone to the Shogunas emergency department first, right here, right? They would have certain procedures to take in terms of evaluating the situation, and that is considered an emergency. Once somebody is diagnosed with some myocardial infarction, that person, depends on what they see, that person then is admitted to hospital, through the tertiary care hospital, for more testing and a review by cardiologists or experts in the field in order to make a determination whether it would be safe to send you home, basically, or put you on a treatment regimen. And that is the basic procedures that happen. If it is that they find that the patient is unstable clinically, that patient is then warded for an extended period of time for stabilization in the hospital, basically. Yeah.
And I hear what you're saying, but that's not what they told me, because what they told me, and if I have to stay, they wanted me to stay just so that I could see the senior cardiologist. And they said I wouldn't see that senior cardiologist until the next morning, which is why Saturday I was packed and ready to stay, because I figured that's what they were going to do.
Now we have a lot to get through. Let me just ask, can the patient presume then, Dr. Hamid, that because I know when the intake is done, you get a couple scans, you get your intake scans, that if you have been determined to be stable enough, this may be where the patient is referred to a later care situation, as opposed to immediate warding to deal with what may be an urgent situation. And should the patient be told that then? Because if the patient is told that, they know, well, I am stable, the doctor told me I'm stable, so I can stop being anxious, and we take it from there.
That would be correct, yeah.
That would be the correct thing. Okay, thank you. Go ahead, please.
So like I said, it is a situation where they told me I have to wait to see the senior cardiologist. And basically, you stay overnight there just for them to turn around to say, okay, well, everything came back negative. You didn't have a heart attack, but here's all this medication. Take all of this until we could figure out you could join the cardiac clinic and then to do the tests. So then we could figure out what your issue is, you know? But these things, obviously these things will worry somebody because in the meantime, you don't have any idea.
Just before, just going to get to that now before I move to Member Naked and his area, which is access to screening. Were you satisfied with the information given by the doctors and or nurses about your tests so that you get a sense of, okay, I came in, I have an issue, and well, I am stable, I require further intervention, but it's not urgent. Were you satisfied with the amount of information given to you and how that information was given to you during the interface at the hospital or interfaces at the hospital?
No, I was not.
Thank you.
I was not.
Just wrap up for me and I could go to Member Naked.
Yeah, sure, no
Thank
problem. Yeah, no, I wasn't because at the end of the day, I'm still not sure. And you are playing, you are giving me things on, what's the term I'm using for, you're trying something.
Well, I don't know they're trying something.
No, but I mean, that's how it comes. You
to you,
me,
okay, yeah.
You asked me what my opinion on it is. To me, it is, you're not sure what the issue is. You still have to do further testing. And in the meantime, hold this, right? In the meantime, hold these things and take these things until we can figure out or do further testing.
So you're still unsure of what's really going on with you?
Exactly.
Okay. All right. Thank you so much. The gentleman in the hat, thank you so much. Appreciate your contribution.
Good afternoon to the chairman.
Good afternoon.
Members of the panel, members of parliament, and our esteemed crowd here. My name is Clarence Mendoza. I'm the chairman of the Concerned Parent Movement of Trinidad and Tobago. I'm also I want to say retired, member of the National Parent Teachers Association, the first vice president. My concern today, based upon what I've been hearing, and coming from the member for the area here, I want to believe she's a counselor for the area. Counselor would have mentioned the youth. And I speak for the youth for quite a while, for years now. We all have communicable disease in our family, but my take is the youth. And I'm saying that because our schools, our school system, our primary school, our secondary school, even our daycare systems, where our children go, where no one goes and look to see what they are eating. I'm saying it today because I said it for years. As the former advisor to Minister Garcia on the TVET, I'm saying it again today, that our school cafeterias, our school canteens is not being looked at. I've called for a meeting with the Minister of Education of October of last year, and we just keep getting letters that we will and we will and we will. And I'm saying it today that we cannot be using a document of 1984 to run our school cafeterias. It's there. It's produced by the Ministry of Education and it's out there. This is what our cafeterias are using. And I'm speaking because I visit over 400 schools here in Trinidad and Tobago. I lived in North America for over 28 years working with juveniles. To come back to my country and to see what's happening, to sit with them since 2004. And here we are today, we're talking about governance and management. We are talking about our healthcare system. It hasn't changed much. It's just evolved, gotten older. The same thing keep turning around. The gentleman would have mentioned clearly of the fact that he has to go all over Trinidad to get one pill. The fact that he has what he mentioned here, to go to the health center and has to wait over a year to get his appointment. And I'm coming to that. But I'm saying our children must be taught about communicable disease within the school system. They must be taught about it at home through their parents. Don't wait till we are old, 50, 60 years, and we are saying, well, okay, well, my blood pressure is real high, I have diabetes, they say so. No. I think our youths need to be taught, need to be tested within the school system. We are being tested for everything else. Let's check their blood pressure twice a year. Check them for diabetes twice a year within the school system. Now, I'm moving on to something that's very critical and is close to my heart. And I want to believe that each and every one of us in here will know someone who suffers from dementia or Alzheimer's.
Well, what I'm going to have to do, we have a specific mandate for this committee.
Okay.
And it's not, you're going out of the realm of that. So while it's important, we're trying to stay focused on what our mandate is, okay?
Well, Mr. Chairman, I understand your mandate, but my discussion where I brought up dementia and Alzheimer's is based upon the scheduled time when you go to the clinic with your patient or your close ones the first time.
Okay.
It cannot be 9 months for the clinic to tell you come back 9 months to have your relative tested. And this is what the gentleman is stating with his surgery, but it happens in every different part of the medical field. That's all I have to say. Thank you, sir.
Thank you so much. All right, we're going to, I'm going to take your contributions, but I'm just going to let Member Naked, because we have to get through the 5 areas, and you can integrate your comments into the areas also. Member Naked is going to do access to screening.
Good afternoon, everyone. We really appreciate your contributions until now. I would like to just, Chairman, just stay a bit with the gentleman who spoke about your aftercare service. That it's over a year, it will be your next appointment is scheduled for September 2025. So my question basically was, what we are aspiring to be a first world healthcare service. Aftercare service is as important as the actual service that you received. My question to the audience is, anybody else has had similar experiences in that time frame?
Can you go to the microphone, please?
Can you give us, so the committee here, we can have some anecdotal evidence of it?
Hi, my name is Michelle.
Can someone help her pull on the microphone, please?
I am 59 years of age. I'll be 60 in May. For the past 10 years, I have a lot of health issues. Now, last year, I was referred for glaucoma and cataract in the Mount Hope. I got an appointment for June. Then they called me back and said, we have to reschedule, so you'll get it for January this year. January this year came, nothing at all. And they said, well, you know what we'll have to do is get back to you. I have been calling and you get no reply. Now, in the eye clinic, in the clinics that you go in, they tell you to reach there for 8 o'clock. And then they don't see you until later. So I am still waiting for my appointment. Actually, let me rephrase it. If I had waited for the appointment, I still have to wait again. In the interim, I made rosary, sold it, and got my cataract surgery done. But I have glaucoma, and the medication is not on the CDAP form. I have asthma. I'm now type 3 asthma, and the medication is, oh, we don't have it, but we do have it privately, but it's not on the CDAP form. For your anxiety, we don't have the medication on CDAP, but you can buy it on the side. For your depression, you can get the medication, but we don't have it right now, right? This is what we keep on going through. And I mean, all protocols, you really don't know what is going down there. For us who are in the middle to no income bracket, not being able to access money for just basic medication, or even going to a doctor, it is the hardest thing, and sometimes you sit down. My friend, who could not come here today, was not diagnosed properly in the eye clinic, and she has lost her right eye, where her retina was removed when they were not supposed to put injections in her eyes, and they did. We have a new person in the eye clinic who also stated that privately and in the clinic, right? Now, I'm going to give you all some more information about me. I used to be a personal assistant to a minister of health, right? And I saw the crap that was going on there. We even went in incognito many occasions in many of the areas, even at CDAP, who turned around and said, a lot of the private entities are buying the medication and they are putting it into their private places, right? My best friend died in 2016 of cancer because they never got the medication at St. James, never having the medication.
When you say, Michelle, that they're buying it and putting it into their private institutions, what does that mean?
What they're saying is that the things that's supposed to be on the CDAP form, the private medical facilities, which we all know how many have gone up, are buying out the medication. So for us who cannot afford the medication, trying to get it on CDAP, you're not getting it. So for instance, this week, I was being diagnosed with type 3 of asthma. I am now fully on board with a nebulizer, etc., but it's not my issue only. The fact of the matter, I went to the pharmacy to buy my medication, and they said on the CDAP form, we don't have this, we don't have that, we don't know when we get it, we don't know when the ministry is going to get us, but here now we have it on the side. So it cost me, gentleman and lady, $1,200 of money that I don't have to buy my medication because I want to make a difference in the medical field that needs to be done with what is going on in it and in these hospitals.
So just for my clarity, so the medication prescribed is on the CDAP list,
yes,
but unavailable.
Correct.
Unavailable, full stop, or unavailable at the places that you visited to try to get it?
Unavailable at the places that I went to get the CDAP.
And do they give you a sense of what the wait time is in the public healthcare institution?
No.
So they just say it's unavailable?
Yes.
I have another question just before Member Nakit continues. Now you've identified more than one medical issues that you're dealing with. You said you have
I could write a thesis.
Well, I'm glad that you're still here, but we really, God is good. Eye issues, respiratory issues, and other issues.
Correct.
So based on what you've identified in terms of trying to, because each of those is dealt with in a different part of the hospital or a different hospital altogether.
Correct.
How does that work out for you?
Not good, because, sir, it's always been, if I want to go to the heart clinic, then I will have to be referred to by a doctor or the health center. And then the health center don't want to refer you because they say, but we have it under control. So it's about accountability. We need the people to be accountable. The CEOs of the NRHs need to be accountable. Their staff need to be accountable, and the boards need to be accountable. What you all are doing here, I take 100% off for you all, but I'm sorry, this is only the first one I heard about, right? And I mean, we have a lot of people we could have brought out here today, because this is an issue. I mean, my minister was supposed to bring out the one card. Where is the one card? Where are those policies that's supposed to be there? For patients to go to St. James for cancer, people are coming from quite Mayaro, have to travel up all the way to St. James. We need a center in the Chaguanas area that can be accessible by every single body. I will go and sit down and talk to patients if you want me to, because I did it for 16. My mother had cancer too, and that was another thing. Thank God she had money. I don't have it. So I sat down. But, sir, it is horrific. You all are not on the ground. You are not the grassroots people. And if you listen, I'm sure many of them will say the same thing here. The worst thing to do is to go to the clinic, and they tell you come before 8, so you could do your blood pressure, etc. And then you might sit down there until 1 o'clock in the afternoon, waiting patiently, and then they tell you, because of what you're going for, you cannot eat any food. So now you're hungry, you had developed gas, and then next one you know, they call it a heart problem. I'm going to move from here now and go back and sit down.
Thank you so much, Michelle.
Thank you.
Anyone else wants to comment on this part? Member Nakit? Thank you.
Good afternoon, everyone. Good afternoon to the panel. My name is Parasram, and I work in insurance. Basically, I just have a list here of more stories that I was involved in, and people who are close to me are friends and clients that were involved in, right? And of course, we are understanding that based on the panel's reaction that you don't understand what is going on in the system, and that is very important. My uncle was diagnosed with AWS, which is alcohol withdrawal syndrome. And probably Dr. Hamid out of everyone will know what that is, right? And when you're diagnosed with that, at some point in time, you start to see things. And you have to be restrained at the hospital. My uncle was restrained in accident and emergency at Mount Hope and then went missing. He was lost for a day. We have to go and make a police report, and they found him up in Maracas, St. Joseph, because we put him up on social media. Where is the hospital management to account for patients like that? Yeah? It didn't happen once, it happened twice. By the grace of God, and I thank God that this is happening today, because this system in Trinidad really needs to be improved apart from the national security system. The second time, I found him wandering on the grounds of Mount Hope Hospital, not too far from the South Security booth. And it was prayers that made me find him. How it is that it wasn't made aware to security officers that somebody who is a patient who has been restrained cannot be found. Second, I had a friend who was in a vehicle accident. The van turned a few times on the road. So being a good friend, when I came to the crash site, we took him to accident and emergency in San Fernando General Hospital. Went through triage in 5 minutes, and we stayed there from 8 p.m. to 2 a.m. in the morning, and no one saw him after that. He got fed up and said, we need to leave. That same friend, a year later, was having terrible headaches, really bad headaches. We went to a private doctor in Shogunas who is no longer with us. He wrote a referral letter for my friend to get a CT scan. He told us, don't go Mount Hope, because you're not going to get a CT scan until probably in the morning. We still wanted to have some faith in the healthcare system. We went there from 7 o'clock in the night, again, went through triage quickly, a lot of people there, stayed till 3 o'clock in the morning, and the doctor is still yet to see him. He had to go privately afterwards, a private institution, to pay $1,500 to get a CT scan. Thirdly, I know someone who required heart surgery after having a heart attack, personal friend of my family. And because he has a wife that works in Mount Hope, the earliest date he could have gotten that surgery was within 6 months. I have a client who got a scrotal hernia. Through insurance, he went to a private hospital. Private hospital saw him immediately. The bill was $30,000 to do this surgery. I told him, listen, we will take 24 hours to approve this insurance. If you want, go to Mount Hope, because you're in pain. There are 5 of you on the panel. As a man, you would understand the kind of pain he is going through, right? When he went to Mount Hope, this was in December of 2023, they told him, join the clinic, and we'll probably be able to do this surgery for you in 2025.
For scrotal hernia.
For scrotal hernia.
Which is excruciating.
Excruciating pain. He's a sole breadwinner. He can't go and sit down on the truck to drive and do the work that he has to do.
So that wasn't considered an emergency?
Well, I can't say that. I am not working in this.
Nothing that's crowded for 2025 could be reasonably considered an emergency.
There are people now, clients that I know, need hip replacement, in dire pain, and cannot go to the public health sector to get it solved. A young man from the ministry called me. He said, Mr. Parashram, I get a number from our friend. I hear you work in insurance. I want to buy a plan. But it was too late for him. Crying on the phone. He tried to get a visa to go to the US to get his surgery done, because they told him they couldn't give him a date to replace both hips. In comparison, I've known people who have traveled to the US and gotten surgery within a week or a couple days. There was someone, a client of mine, a sister, needed a stent at Mount Hope. She told me they couldn't do the surgery because they said they didn't have any stents. I had a friend who is here today alive, father of 3. He had COVID. He was in the COVID tent down there at Mount Hope. And if someone did not recognize him, when he was dying, because he was telling the people attending to him that he was dying, someone who's a ward assistant did not recognize him, take that bed and push him up the ramp for accident and emergency, for those who know what that is, and tell the doctors, this is my family, will you please send this man to Kuva ICU so he could be saved. That was the only way he's alive today. I had another client that had a stroke, ended up in Mount Hope Hospital. They told her there that the brain surgery you need to do that could probably save your life could only be done at a private hospital in South. And that the ICU care afterwards would cost you $1 million. Of course, they couldn't afford it. It is by God's grace that she's still here alive today. And all these people, if the committee wants to be able to contact them, I could give you the information so you could verify. I just want to give some solutions. And I think the main solution that we need to have is we need to stop going into the parliament and clapping on the tables and clapping our hands that we build a new hospital. The country does not need new hospitals. The country needs better hospital management systems. And I will give you my private story. I was getting some head pains. Because I have insurance, I went to a private health facility. In 2 minutes, I saw a nurse. Right after seeing the nurse, I saw the doctor. Right after seeing the doctor, he said, Parasham, based on your condition, we need to do an MRI. I'm scheduling you to come back 2 o'clock tomorrow to have this done. And that is what I think the people of Trinidad and Tobago need. A hospital management service that can schedule things. What is the point having someone sit down there waiting 10, 12 hours? The only time the supervisor will come out to give and render any assistance is to tell the visitors to leave the waiting area because they're filling up the area. When you go and you ask for status on your relative, it's like pulling teeth. The banks in Trinidad and Tobago, due to information management systems, could pull a report for you in 1 minute and tell you how much money everybody have. Why can't our healthcare system do that? To understand the number of people that have diabetes, have high blood pressure, etc., to make sure that we have the medication that this lady needs to be able to address it. I just want to ask a question. We have taxes and duties on alcohol and tobacco. And Dr. Hamid would have pointed to two of the most important things that is causing the NCDs in our country. Is it that this committee is going to, and you don't need to answer, right? Is that this committee is going to apply those same taxes and duties on those products that are destroying the nation? I will leave with this one question, and you all can think of the answer in your mind. If you need heart surgery tomorrow, where are you going? Public or private? Thank you.
Thank you very much, sir.
Thank you for a very candid contribution. I just wanted to ask you one question as a follow-up. The person you spoke about who was found in Maracas, St. Joseph, they were suffering from dementia or Alzheimer's? Huh? Alcohol withdrawal. Okay, thank you. Well, my question for you all is, it's a combination of things. With your access to screening, have you encountered any difficulty when it comes to specialized doctors to have that screening for a particular ailment or lack of equipment? Anybody has experienced any difficulty in getting access to that screening because of those different factors? Let us know. Please.
Gentleman in the back, his hand is up. Thank you, sir.
Mr. Richards, what I'm seeing here is that the RHA have failed.
Could you just speak up a bit, please, so we can hear?
The RHA has failed to the point. If you talk to nurses in the hospital, and Mr. Richards, you will probably get good treatment. If one of these guys go there, if they shut themselves, they clean themselves, or they wait till the relatives. So the management in the hospital, down. As you talk about access to things, Dr. Hamid, you made a good paper, a good presentation. What is your policy to monitor diabetes and hypertension in the hospital? And what is the frequency of the policy?
He is asking if there's a particular policy
You have
to
a
monitor
policy
diabetes
to
and hypertension.
monitor diabetes and hypertension, lipid profiles, right? Your renal function, your liver function, your CBC and differential. What is the policy and the frequency of doing that in the hospital, in your hospital, or in your health centers?
Dr. Hamid could only do generalized responses.
He could answer
not,
that.
Yeah, but he's
He
not.
could answer that.
Yeah, but he's
But in any
not
case,
here.
I'm telling you not.
Sir,
The policy, sir, is
sir,
every 6 months.
Sir,
Yeah.
can I just interject?
Sure.
Dr. Hamid is here as our guest to speak about the overview of NCDs. He's not here to respond on behalf of the Ministry of Health.
Okay, all right, thank you.
Thank you.
So the policy is every 6 months. Do you know patients get referrals every year? Some years pass and they don't even know the numbers. I am telling you that the government, as somebody said, don't know what they need, how much tablets of A or B or C. You know why? Because they don't ask people who know. You know, in Trinidad and Tobago, we have something called a unique identifier. Mr. Richards, you know we have something called a unique identifier?
A unique identification card?
Yeah, identifier, not a card. That's
Unique
part of your birth
identifier.
certification. Every person in this Trinidad from 1934 to present and ongoing has a unique identifier. So people in the hospital, if they are properly organized, could tell you how many people have diabetes, the exact number. What are their needs in terms of medication, and what not and what not. And when people talk about this CDAP, CDAP is 30-something years old. Those medicines doesn't work again. They have new medication because people have side effects to it. What is the government doing about it? It is not doing anything because the RHAs are not accountable for the money they get to spend. In San Fernando, in the eye clinic, the machines are not working, but they want to buy a cheaper machine. They are advised by the specialist, that can't work. What happens? The lineup for cataract surgery increases. You understand? Okay, but I will go to Dr. Ahmed's area of prevention. And we have a sportsman in the committee. What is the intersectoral aspect of communication with the health and sports? We have agriculture. What is the intersectoral development between agriculture and that? We spend $10 billion to import food. Right? We import things like what? Tomatoes and lettuce and things. Right? We import strawberry in this country. We import aloo or potato. What's going on? Something is wrong with the policies of government. You need to sit down and talk. And don't only talk in parliament, come out in the communities. Not only like this big one. Go to the villages, you'll understand what is happening. Cancer care, I teach. When people in Africa, they don't have a problem. When in India, they don't have a problem because they eat cassava and ground provision. When they go to America, they eat fine food, so they get cancer of the colon. In terms of cervical cancer, doc, they have a vaccine to give everybody. Nobody gets it. Some people get and some don't get. Why? Do you know PAHO reported 25% of our citizens who entitled the vaccine not vaccinated? Why? So the whole system has broken down because of poor management in all the sectors. The Ministry of Health is not monitoring what they're supposed to do. The RHA fighting for money. And nothing happening. They're not using the information system they have. Okay? Now, Mr. Richards, I will let you know, I was the principal medical officer for Trinidad and Tobago. Next door, we had a chief medical officer for Trinidad and Tobago. But nothing is happening. Things are going down and down and down. So people need not to come here to complain that A and B is not available. Everything should be available. It is cheap. We can run the system with the same money and everybody can get it. But it's not really done. Thank you very much.
Thank you,
Mr. Chairman, just before, sir, just before you leave, Mr. Chairman, tell me something. So in terms of, we hear about the systems, we hear about the government and so on. The people who are running the system, right? The administration, the head of the RHA, the staff, down to the clerk, and where does they fit in terms of, where do you see them fitting in terms of what might be happening with the health system?
Well, it's difficult for them to fit in because they're not trained, one. They lack interdepartmental training. They lack in-service training. I left over $100 million for postgraduate training, USA. How much people have they trained? They bring in people from Cuba. So the money is misspent, all right? And I feel hurt about it. But I worked very hard, and I had this country with no measles, no this, no that, no yellow fever in the country. And you come now when you have everything? If I ask my friend here, how many diarrheal disease do we have in this country? He can't tell me because the surveillance system in the Ministry of Health broke down. Okay? I was an advisor to a local government. I asked the county medical officer of health, what is the situation with A, B, and C? Because I need to advise. He said, you will have to go to the ministry. That is private and confidential. When I was in charge, everybody know everything. It's not secret. They had a secret with COVID. All right? So the whole system we revamping, the RHA needs to be totally looked at and revamped, especially the management aspect. And by the way, I was part of the development.
Yeah, but again also, additionally, we have been informed at other forums with regards of systems being in place, like for instance, the prescriptions that we're talking about and the availability of the drugs, that at Shogunas, they can pull up on the system, see where the particular drug may be available, Mokoya, Tunapuna, Takrigo, Diego Martin, and they can so inform the patient that, listen, you can go to Diego Martin Health Center in order to receive it. But are the people or the clerks doing those particular aspects? And I think this is where...
If they are not trained, they cannot...
So training.
But
Clearly.
next thing,
Thanks, Mr. Chairman.
a specialist in a hospital prescribe A, B, and C. The fellow in the health center, he don't have access to that. So the health centers don't carry those drugs. So you are forced now to find money from your pocket. And the government is not indexing people's pension, or the index parliamentarian pension. So the rest have to suffer. I'm talking about civil servants and teachers and everybody. It's a fact. Okay? It's a fact. So you're increasing poverty. The level of living is going up. All they do is cut the bloody, the thing from custom, cut it duty, and things will go down.
We're going beyond the hope.
So I know, I'll stop at that, but it's still...
the young lady wants to make a contribution. But I understand the connection you're making, but I want to stay on focus here. Thank you so much.
Economic cost is a big thing.
Thank you.
A very big thing. All right? Let me talk.
Thank you. The young lady was wanting to make a contribution. I think her hand was up.
Good night, Mr. Paul Richard.
Good evening.
The head table, I know everybody there. Good night to my former colleague. You don't answer your phone. That's a joke, my former colleague. Mr. Richard, could I kindly ask for what you had on the system there earlier, please, which is not the Regional Health Authority, because I think we strayed from the point. Could I see the board that you had the original?
Actually, we're not straying from the point.
No, I'm not
We're going in a
you.
particular order.
Okay, well,
what would you like to contribute on? You can go ahead.
I would like to see back that board first.
Can we go back, please?
Right, and I'm staying there because I think I am from Shogunas. I could stand here and say I represent Shogunas. These cards in my hand are official North Central Regional Health Authority cards. So when I speak of facts in my hand and what I know. You all are here under North Central Regional Health Authority, which is a fact. Firstly, I'm disappointed. I'm not disappointed in you all, but when I heard this mentioned in my committee, I said this was a good opportunity for me to actually see the CEO, I think he is either the CEO chairman of North Central Regional Health Authority, which is Mr. Davlin Thomas. So I think when you're going about your next meeting, it would be nice at least the CEO of the Regional Health Authority could be in the present to hear our plight. That is one.
Can I respond to that?
Yes,
Can I respond to that?
You.
Okay. Mr. Thomas
Yes.
is not a part of this committee.
I know
this
that.
is a parliamentary committee. What will happen here is we are taking notes and we are taking your feedback to create a report, and we will have Mr. Thomas before us, before the report is committed, to challenge him on what we are hearing from you. That is why we're here, and Mr. Thomas will more than likely have to answer to the feedback of the public on the ground. That's why we're coming to you.
I heard you, but allow me to reiterate, because apparently you didn't hear what I said clearly. I said he don't have to be in the committee because he's not part of the committee. But if he could be invited to sit among us, well, okay, I understand
Not
what
a problem.
you said.
That's a suggestion we're willing to take on.
No, I am hearing a lot of people talking negatively, since I'm sitting here, about North Central, the Regional Health Authority. This is North Central Regional Health in Monthope. In my cards here are my own family members and friends who have been to North Central Regional Health Authority, which is Monthope. I must say, from since 2005 and back, there were bad issues. Right now, there are simple issues under North Central Regional Health Authority, which could be improved. One, attitude. That's a major factor. Attitude of some of the staff that you have to relate to from the time you leave your home and reach there 5 o'clock to put your numbers. Some of the doctors, especially specialists, are very helpful. Some of them, they don't attend to you. They put you onto junior staff who have to go over your file every time you go there from top to bottom. It is very uncomfortable that every time you go to a clinic, you have to see a junior staff. They don't even know exactly, and they have to be asking you, what is your problem again? It's very unprofessional. That's number one. I don't know if other people experience it too. I have experienced it. Number two, when you go there to the health center, why is it that if you get a prescription, whether you go dental, whether you go any of I'm sticking on Monthope, you have to be seeing people waiting there 5 to 6 hours in the pharmacy from 9 o'clock in the morning to 3, 4 in the evening. You take a number, you have to sit down there and wait. And the people in the back, they are not friendly. If your back not well and you explain to them, if you have something, they don't even give you a little blind. That is one of the areas we need to pay particular attention in. That pharmacy in Monthope, it is very, very unfair that citizens have to be sitting down 4 to 5 hours to wait for a prescription. Another thing, I am very, very much disappointed with the health facility and the health expectation that I have and many people have that we experience in Shogunas. And I want to say here, and I don't care who vexed the night, from MP come and go to councillors, nobody care about the people of Shogunas. We have the worst health facility in the whole country. Every time I see my Prime Minister turning a sword, it's from some hospital somewhere. They go Martin. I remember I have 2 hospitals. Where is the hospital for Shogunas? All the years I have known myself, since 16 years, we're using a hospital as a health center hospital. That was a gym. That was a gym, and that is what they have been using in Shogunas. Recently, they opened a new building, some rental building somewhere along the street here. If your back sick, if your foot sick, if somebody old, they can't even go up to the emergency. They can't go up to GP. You know why? There is no elevator. Who consulted with us from Central? Nobody. You have members of parliament, them in hard time. Councillors, them in hard time. So you catch yourself or you can climb up the step. When there was COVID, right? This is something in mayor and them. I have to pressure them. When there was COVID, all over the country lockdown, one main street, it have by the hospital there. The ministry decided to fill that street with tent. So when you go there in an emergency, there is no way for nobody living in Shogunas or environment, all the 8 electoral districts under Shogunas Borough Corporation, you can't park no way. You can't park in the hospital, in the car park that they're renting, that is for hospital staff. I'm talking about the hospital in Montrose. You can't park where you used to park because the tent's there. The only way you could park is on John Street. And when you park on John Street, consider your car gone according to the make of vehicle you have. Who consult with us? Who care about us? When you go to the health center downstairs there, you meet an attitude. Why it is if I or anybody go with a family, the first person you meet is the security guard, and you have to tell the security guard exactly where it's hurting you, how it's hurting you, and how you're sick. Why? Why my private business have to be to the security? And this is what we have been dealing with in Central. And you know what? All who sitting down here, ask them one day to come and protest. Nobody can go protest. But we in Shogunas have the worst medical facilities. The worst, all over hospital village. I just want to ask you politicians on top there, why you let us skip Shogunas? Why? Prime Minister going all quite down south. They go on Rima. They go on Point 14. They go Martin. When I put on my TV, nothing happening in Central. But we are MPs, we are councillors getting paid, we are mayors getting paid. You know what happened? I need to be the MP and I need to be the mayor. That is why I'm standing here today. Because I am fed up. I am fed up of the attitude we getting. All of us here paying taxes. Shogunas flood with Spanish people. When I go to the health center and I have to sit down and wait 4 hours, a Spanish go just walk in, tick, 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 show a doctor, show a nurse, he does carry it and give the doctor. I sit down paying taxes, you know. I have to wait 4 to 5 hours. The Spanish walking in. So what is going on? What is going on in my country?
Can I interject now?
Yes, you can interject, Mr. Richard.
Okay, I acknowledge what you're saying. That is why we're here. We are here, and I can hear the anger and the frustration in your voice.
No, I'm not anger. I'm not anger. That is how I speak.
Can I? Okay, that's fine. I hear the passion in your voice, right? And we are here to get your feedback. We cannot solve the problems here, but we are taking note of your feedback, which is very important because you are the ones who are experiencing this, and you are experiencing the gaps in the system.
Yes.
And they are very common trends in what you're saying. What you all are saying is not very different. And I can just imagine how frustrating it is. But what we are here to do is listen to you and take notes so we can challenge the authorities and get answers from them and give recommendations, and hopefully it will improve. I'm going to ask you to just wrap up now so we can move on to the next section.
Sure. I would like you to take this message and kindly ask Mr. Davlin Thomas this one. The Shogunas Health Facilities, which is the old one and that old one there. Doctors there need to be specialized. I am speaking here in quotation. Apparently, the doctors that operate there, especially in the emergency department, they are not specialized. You cannot tell me you get a fall, you damage your spine, you damage your back, you wait 7 hours to see a doctor. When the doctor do take the x-ray, then call you in up to now to examine your body. You wait 7 hours, at the end of the day, they tell you nothing wrong with your spine, nothing. You get no x-ray to go with, to go and get a second opinion. 2 months after, you can't walk and all kind of thing. But when you left the hospital, they get a trauma set, a painkiller. After you now damage your spine, you get trauma set after 7 hours. Doctor didn't check you yet. You decide to apply for your file. When you apply for your file, I'm advising all of y'all, don't trust health facilities. When you go to visit a doctor, apply for your file. That is your right. When you apply for your file, nothing that when you went there that day is on your file. Something is wrong in this country. And I am one who's going to sue the Ministry of Health for that. Something is definitely wrong. There's no specialist at Shogunas Health Facility, and something is wrong in the way they address your issue when you come there. If you don't have money in this country, crap is going to smoke your pipe. And we don't deserve that. We pay in NIS, we pay in health. So that my 4 parents pay these things, and it is unfair that you go to a health facility and the doctor just writing trauma set for a serious issue. And next thing, they're supposed to give a referral letter to go Mount Hope. After you go to the clinic, to go to any of the regional health authority, you must have a letter. Why is that not being done at all times? Why? So I would like the chairman of the regional health authority, which is the one that I am living under, to look into this matter. Also, my last thing, there was a doctor at Shogunas Health Facility. Everybody every day right now is asking for that doctor to come back. I think her name is Bernstein, a short, nice doctor. The best doctor you can ever have in Central, a Cuban doctor. the best doctor you can have in Central, that Cuban lady doctor. I am appealing to North Central Regional Health Authority, look into the matter why she's not being brought back to Shoguna's health facility. A doctor that stayed 24 hours when her shift is over, you could still reach up there 5 o'clock, minister 7, and she's still there. That is the kind of doctors we need. Dedicated. One who will check you, see your issue, and give you a referral and tell you go and get further medication or attention. That is what we need.
Can you share your name with us?
My name? Oh, I didn't give you my name, Mr. Richard.
No, you didn't.
Mr. Richard, I'm a former alderman. My name is Catherine Joffrey. Thank you very much.
Thank you so much for your contribution. Let's just let Member Ford introduce the next section, and then we'll take your response. And we have 2 hands up in the back. Thank you. Member Ford, go ahead, please.
Thank you, Mr. Chairman.
I think your mic is off.
Check 1, 2, yes. Thank you, Mr. Chairman. Okay, have you encountered challenges, again, question being put out, have you encountered a challenge with accessing treatment or keeping appointments due to the lack of equipment at a public health institution or staff shortages? Unanimous. That's a normal thing. All right. Okay, no, again, all right, fair enough. Do the challenges in accessing treatment from public health institutions deter you from seeking medical care from these institutions? All the time.
All right, okay. Let me just invite this gentleman to comment, and then the lady in the blue in the back, so we could get direct, and then the gentleman in the green t-shirt here, right? And then the gentleman there. Sorry about that. That's why we're asking, you know, and I know people have a lot to say, and we appreciate your feedback, but we're trying to get in as many people as possible. Okay?
Good evening, everyone. I am Dr. Katamanchi. I am coming from Geriatric Society of Trinidad and Tobago. Anyone knows what is a geriatrics?
Could you repeat that, please?
Anyone knows what is a geriatrics? Geriatric medicine. Geriatrics. No. Geriatrics, yes.
Geriatric. If anyone here is a geriatric, that's what you're asking?
Yes, please.
Yes, well, from my perception, I'm seeing several geriatrics. I might be included in that, so that's not a problem, yes.
What is a pediatrics? Yes. So the children, we calling pediatrics. The world,
pediatrics.
Pediatrics.
Okay.
The world people, we say geriatrics. The geriatric medicine deals for old people health. Here I am representing, of course, we have a lot of health issues. We're talking, somebody saying we're not getting medicine here, we're going next health center, we're not getting. And the point here is, we need to take care ourselves to not getting sick. This is what today's topic. Preventive medicine. Dr. Hamid represented a nice presentation on what non-communicable diseases we are getting. At the same time, we need to consider who is admitting in the hospitals, what is the frequency they are admitting, who is a vulnerable people in the society, pediatrics and geriatrics. Why geriatrics? So when we're getting old, you know, our immune system also making changes. We need prevention, better than cure. This, how we going to prevent? What is a prevention? So you need to take care of yourself, not getting sick and getting treatment and rehabilitation. Small example, diabetes. Dr. Hamid said diabetic, they're getting neuropathy. What causes neuropathy? You will get ulcer. Ulcer getting big, and you need to go to amputation. Or you're diabetic, not taking care, sugar uncontrolled, you're getting gangrene, you go in and amputating. Then what going to happen? Your quality of life going low, and you go in and seeking social help. Here what I am saying is, I am not talking general health, I am talking especially about the old people who frequently admitting, getting sick, and using medications. You need to take care yourself. How are you going to take care yourself? You need mobilize. Mobilize means activity. And you need to see mental health, mental health. Everybody talking mental health. What is a mental health? You are alone staying. You have medication, but you don't know what time to take, how to take. and because your mental health is not affected, you are depressed, you're not taking proper medication, and again, your health is jeopardized. So my point here is, we have a few resources to special care offer to public, especially old people. Health center, you cannot go. People living alone, people bedridden, how are you going to get treatment? How? So you have no transportation. Some of them saying, I worked in, I giving small example, when I was working in Port Aswan General Hospital, emergency, a lady used to come every night, or at least every other night. One day we vex and we say, so why are you coming every day? The lady comes with a box, 7 days, and 3 portions of medication. She's a diabetic. Her medication all comes from US, but she's not taken on time. She coming every day and sitting in emergency and coming inside, chatting with the nurse, 1 hour, 2 hours, then she go home. So why? She's feeling lonely, she's depressive. So you need somebody. Who is somebody? If you have relatives, neighbors, you could chat with them. That is a mobility, social interaction to get at least mental health. And I'm not going to give all these risk factors, but what we need in health system. Health system, we need a special clinics for geriatric people, which is the old people. And we saying elderly, elderly. What is elderly? So one day you get elderly. Okay, I am going to get elderly. One day I'm going to pass away. And what life I need a quality of life. I don't want to get amputation. I don't want to get cataract. I don't want to get what is called cancer. And they're saying hospital admission, upper GI bleed. Where are you getting this upper GI bleed? And we need to see the medication, what we prescribing. Somebody mentioned how my next appointment is next year. 1 year, you're using the medication. You don't know what is the complications. You don't know how it is controlling or not. And for small example, aspirin we're still using, I think we're still using in the country. Yes, Dr. Hamid, we're using aspirin still. Aspirin, some countries banned. Why they banned? Aspirin causes bleeding. You could go and check statistics. How many people admitting with the GI bleed? If you have any healthcare professionals here, most of them, 60 to 70% are old people. And if you take an aspirin, you need some other medication to protect your stomach. Sometimes you're not getting that, out of stock, you're not getting, but you're still taking aspirin. If you're not taking, you will get health issues. Here, my suggestion to the government, to the committee, we need a special clinics for old people. And we need special wards for old people. We need special interest groups in the community to engage the people not getting the sick. How this going to be work? What is taxpayer money you're collecting and you're spending on healthcare? Same time, you could consider some people who taking care and revise what the medication they're taking, how that affecting, are they taking or not? If it is possible, a bedridden, single person staying at home, you could go home visits too.
Can I ask you to wrap up?
Yes, sir.
Because we're trying to get through a lot more. And I know you're representing the TNT Geriatric Association.
No, it's not representing, and I am bringing my concerns to take care, special care for old people.
Yeah. Okay. Thank you so much.
Okay?
Yeah.
All right. Thank you.
Thank you. The lady in blue and then the gentleman in gray just in front of her. The lady in blue, sorry, the gentleman in blue, sorry, my apologies. And the gentleman in gray and then the lady in purple.
Good evening, everyone. I would like to talk about the CDAP program and the distribution of medication. When you go and get your CDAP medication, today, you go in a month's time to get the second set. The problem is that if you have to get more than one medication, let's say you have to get 5. Today, you get 4, but you don't get the 5th one. If you get the 5th one is available in 3 weeks' time, what happens is that a month from that 3 months is when you'll get your next set of medication. So your next 4 medications that you were supposed to get, you'll have to wait a month. So you have lost 3 weeks for your 4 sets of medication. So what it should be is that it should be a month from each medication you get, as opposed to the last time you got medication. When this medication is not available, they say you can go to any other pharmacy and get it. That may be in theory, but it doesn't happen. When you go to any other pharmacy, they send you back to where you went before or tell you it's not available. When I asked a friend of mine who's a pharmacist why that happens, is because they keep the medication for their patients, for their customers. So it's not available everywhere else as the ministry has it. Thank you very much.
Thank you. Just before I ask the gentleman to comment, Member Singh, could you just give your overview? So I know Member Singh has to leave us for another appointment, and we will include those comments in terms of his section also. So go ahead, please, Member Singh.
Thank you again, Mr. Chairman, colleagues on the head table, and of course, the citizens of Trinidad and Tobago. Based on all the discussions so far, it is critical that we as a committee, we really take the initiative and record accurately all of the suggestions. And that is why, Chairman, with your leave, we are here in Chaguanas, because it's really this opportunity for you to understand the Parliament is actually coming to you. And on this occasion, all of your views are going to be taken into consideration that will be reported back to the Parliament and therefore the Ministry of Health. I just wanted to turn to one of the topics for discussion before I take my leave. In relation to prevention, because in discussing some of the challenges, one of the speakers earlier spoke to the connection between my friend David, where sport, myself, where agriculture, and where health is concerned. And something I always tell people, we oftentimes talk about the relationship between the food import bill and our country. But I want to turn the conversation to you, because you as a consumer, where health is concerned, what you put into your bodies directly affect your health. And I'm simply going to say, when you talk about the food import bill, you directly affect the food import bill in terms of what you purchase. And somebody mentioned KFC and the lack of persons purchasing and whatnot at this point in time. I'm simply saying you have the power. You have the power to demand, or you have the power of spending to buy proper food. And something we have done in terms of as a government initiative is these farmers markets that you are seeing all over, where we try to connect you, the consumers, to the farmers directly in bringing down, because somebody also raised the fact about it's expensive to eat healthy, and we understand that. And so I just wanted to put that on record, and I'm going to ask now, do you all, in your opinion, do you all think that the government at the state level is doing enough to educate you all about the preventative measures, right, and the public awareness initiatives? What do you suggest the government do to improve in its strategies of encouraging men to seek early screening and treatment? Because as you know, men tends to be a lot shy. Chairman, I'm quite happy to see so much men turn out to this session and being very vocal and putting their positions forward. But in the overall concept, what can we do to encourage men to really come forward? Because as the statistics show, almost 50% of the population is living with a problem, but they don't know that they're living with a problem. So these are just some of the points I wanted to put on the floor, Mr. Chairman. Thank you for that opportunity, and to just engage the discussion and going forward.
Thank you for being with us also, Member Singh. Member Singh has to leave us now, but we thank him for being here. The gentleman, and then we will take the lady right in front of him.
Thank you, Chairman. Good evening to the head table and to everyone present. My name is Maurice Jones. I'm a Minister of Religion. And I want to commend you for coming down to the place I like to call Chaguanas, coming to us to share this information. I listened with a great deal of sympathy and empathy to persons who had issues, and I know personally of persons who would have had similar issues in the health sector. But the quick point I want to make has to do with what's in the board now, prevention. Dr. Hamid mentioned a term earlier which piqued my interest. And I was hoping he would have elaborated on it a bit. And that is the term wellness approach. Because I believe that that's what's going to help us. Developing, expanding on this whole matter of wellness approach. I am not technically, learned enough to interpret, but my layman interpretation is that it has to do with a preventative stance. It has to do with like what you're doing, trying to educate us. It has to do with public education, I suppose. It has to do with our better eating habits, and taking care of ourselves and so on.
Can I ask you a question?
I don't know if I can ask.
Can I ask you a question?
Certainly.
I have seen several iterations of ministries of health in different governments champion the issue of getting the population to eat healthier, to make better choices, to feed their children better choices. And all have failed because we are where we are today. What do you think is missing in that public education drive? What do you think, or is it more than that? Is it a matter of information and access? Because very often, as Member Singh has said, and many others have said, the issue is not necessarily only choice, because you get socialized and weaned on the fast foods. The fast foods are convenient. Very often the fast foods are cheaper, and children in particular like the fat and the salt content and the sweets in the sweetened juices. So it's a very difficult, it's an uphill battle to change those lifestyle and cultural embedded values.
I think it's a kind of catch-22 situation because, and what I think would help would be a multi-sectoral approach to it. Because the Ministry of Health might be laboring. I listened to the Minister of Health. I was worried that somebody might sue him the other night when he was calling names of brands. But he was trying, so the Minister of Health may be trying. But the Ministry of Culture may be going on a different, a different path, all right? So whereas one group is encouraging you to fet and drink and, have a great time, we encourage the carnival mentality and so on.
But the brand,
on one side.
The brand and the question these days, the brand is not putting 3 carbohydrates on your plate.
Mm-hmm.
The brand is not putting rice, macaroni, pie, sweet potato on your plate. That brand is not doing that. That's we doing that. We cooking that because that is our culture.
Yes.
And that is what, so we like to blame the brand. The brand is just one aspect of it.
Yeah, so, and I don't want to be long. I want to simply say it has to do with starting, and someone said it before, at this level of the school children. It has to do with the Ministry of Education. It has to do with the Ministry of Social Development as well, because I personally know poor people that are trying to access grants from the ministry and they're not getting through at all. I know personally I have to be helping out a family, 6 children, all right, no source of income, and the Ministry of Health is not helping them. the Ministry of Social Development. I personally have gone and sought help, and it's not forthcoming. So that is a recipe for getting sick, right? So it can't be just the Ministry of Health. This is my point. And I was actually hoping that there'd be other ministries represented, okay? So I hear you, and we can't give up. We've got to keep pressing, pushing, trying to educate, but I think that we can't be sending mixed signals, all right? The government needs to take a stance. And if we against it, then we know it's against our help. Okay, I'm getting some competition here from my friend who gave such a bold presentation. Okay, but I don't want to stay any longer, but I want to encourage, and Dr. Hamid, perhaps that's something we should develop, a culture around wellness approach. Take a preventative stance. Amen. God bless you.
Thank you. All right, I'll just let my man make a final comment because he also has to leave, and then the lady in purple, and then this lady here, and then the lady there, and then this gentleman. All right, so we have an order.
First of all, I'd like to compliment each and every one here for their contributions. I'd like to speak in my last contribution to the points that the gentleman in the white hat made earlier, and some of you mentioned along with my colleague. But the whole idea, the whole ethos of eating healthy, it doesn't just come, or eating healthier, it doesn't just come like that. It involves a serious cultural shift. It involves not only an education from the government and so, but it involves how we see ourselves, you know, and how we are honest with ourselves and our approach to what we have planned as a people. You know, we didn't have, I can remember, as you do, decades ago, there was seldom any problems for our people in terms of obesity, especially in the Caribbean. And it was the same in Europe. You know, I lived there for over 20 years, and in Europe, you didn't see anybody who was obese. Now in Europe, it's completely changed. So the shift, that cultural shift has occurred, and we need to bring it back. And I think it starts, as he said, the gentleman there. What's your name again?
Mendoza.
Mr. Mendoza. It needs to start in the schools very early. We need to get that understanding and that link between health and how the way we eat and the diet and all of that. So I want to commend all of you, and I thank all of you for your contributions. It's tremendous. Thank you.
Thank you, Member Nakit. The lady in purple, and then this gentleman in green, the lady, and then the gentleman, and then you in the back there. Go ahead, please.
Pleasant good evening.
Could you come closer to the microphone, please?
Pleasant good evening to everyone.
Evening.
I'm Caroline Ruiz. I am from Trinidad and Tobago Residential Care Association. So we deal with the elderly, taking care of the elderly, right? I'm going to take a different turn on the system. And I agree with all of you all that said what you all said about the hospital system. I know it to be that way from since I'm a young girl, right? However, I must say within the last couple of years, which would be maybe two and a half years, that there's a change. And I'm saying that because we deal with the hospital system on a regular basis because of the elderly that we care for. We are now getting discharge forms without having to ask and beg. That's a plus. We are now getting that they are keeping records of the client because they are able to follow up when they call us from what we say to them, because they will call us to ask questions on the individual at that time.
Let me just put some context, and Caroline is talking from a perspective as the head of the
association.
The association of
care facility.
Of care facilities,
Tobago,
elderly care
residential.
facilities. So her interface is in a specific context, right? I want us to understand that.
Yeah.
Go ahead, please.
Right. And the ambulance system, we are now getting them to come regularly. A matter of fact, I am from the West. So within 5 minutes from General Hospital, they take most times, sometimes less, to come to pick up our, which wasn't like that. So that's a compliment to them. And we, as you said, Dr. Richards, that we have to give the good too, right? So I want to compliment the Ministry of Health for that. I also want to compliment them, the wellness centers, because we deal a lot, because I think you all would know now that in many of the homes, we are now accepting mental clients, and we are now dealing with the wellness center and the social workers. And I must say, they are really, really nice to deal with. However, I know that there are issues with the health centers on how they treat with clients that, I should say patients that come in. We use the word clients, the term clients, but patients. Because I visited a couple of the health centers, and there are some of them that really don't treat the clients nicely. And I am one, don't sit by and see something and not say something. So I always get myself involved when I'm in that situation, right? And so there's a bit of improvement needs to be done where the health centers are concerned. However, I think we also have to touch on bed sores with bedridden clients. It happens at a home or it happens in the hospital, right? So it's not nobody's fault. It determines by the texture of your skin and all of that. However, in the hospital, they need more people to do turning and stuff. So because when we send them to the hospital, we're always worried when they're coming back and how big it's coming back.
Would you say, Mrs. Ruiz, that
Miss
that a lot of the progress that you see has been made, particularly related to the care of elderly persons in the homes in your organization, is because your organization has developed particular relationship with the RHAs, and so you have that kind of monitoring and surveillance?
Yes. What we do want, however, what homes want is that we must be able to have a relationship with the district hospital, right? So like, for instance, I am in Port of Spain. I must be able to have some sort of, how to put it? I must be able to, have some foot in to be able to deal with them where my clients are concerned. They don't do that. They push us aside. But what they do is normally they'll call the relatives, and rightly the relatives are responsible. But sometimes the relatives are not around and the homeowner is who takes control. But that is an issue. So that's one of the things that we want to be able to address, or for them to address with us, that there should be some sort of correspondence between the homes and the hospitals, right? Other than that, I understand the plight of the people, but in our situation, we are seeing a shift. We are seeing a change, and we are grateful. Plenty room for improvement, don't get me wrong. Plenty room for improvement, but I can say we are a bit satisfied with some of the things we're seeing, especially with the discharge form. Because sometimes we have private doctors on shift. So even though they come from the hospital, we will get a second opinion by our doctors, our private doctors, so that we know how to treat with the client, right? So that is my contribution.
Thank you so much. Before I invite the lady and then the gentleman in green, I want to add one more topic to our conversation, because it has come up in Port of Spain and it came up in San Fernando and to some extent here this evening. And that is the issue of patient record management, your files, and what has your experience been? I heard a couple of people this evening say, well, their files, it's difficult for them to find the files. And in addition to that, do you think the public healthcare system would benefit from in each of the RHAs, a more effective communication department, so that when you call, they have all the information on the computer and you can give a reference number or your name, and they can look through a computer and say, well, X and Y is the case for more efficient service? Because I'm hearing a lot of communication issues with patients, right? I have to give that a chance. I'm going to come to you. The lady and then the gentleman in green there, please.
Good evening.
Good evening.
My name is Vanessa Gaines Coffey. I am here because I'm a part of the Council for Professions related to medicine.
Could you speak up just a bit, please?
Speak up.
Yes, thank you.
Yes, I am. My name is Vanessa Gaines Coffey. I am a member of the Council for Professions related to medicine, which is the umbrella body for a number of different boards. I am a part of the Radiographers Board. And I'm not speaking from that part, but just looking at what you're talking about in terms of what else can be done. I think that people pay attention and make changes when they feel like you care. The Minister of Health cannot go to every community to show people that they care, but I think it needs to go past standalone one-day health fairs and just promotions that doesn't really touch a person or come to a person, and it needs to go into the community. For example, maybe even operating out of our community centers. And I was looking online and I saw where there was an initiative in 2020 with PAHO and WHO, where there was a pilot training for a self-management program. I had not heard about it before, but I looked it up because I was coming here. And it was that they would have trained 25 trainer leaders who were supposed to then train other persons, and it would have been in the community where you would have them teaching persons to self-manage NCDs. And I guess it can also be looked at in terms of prevention. And I'm saying it's good that the Minister of Health and the Ministry of Health is looking at movement and how persons can stay healthy, but it cannot just be standalone health fairs. It cannot just be where they're just promoting. We are a culture where we like to eat and lime, so let us eat and lime healthily in the community health centers. If we have long-standing programs where we invite persons in the community itself who know how to cook healthy, whatever, and you invite your community's people you know, and you start to talk about how you change. You could eat doubles, but you could change how you make the doubles, and you can make it healthier. You can look at how you're drinking, but if you're doing it at a community level where people know each other, you can have changes happening. But if you just say, okay, we have the market here, so go buy food, we have this, people need to feel that people care. So the ministry needs to empower the communities even more with better resources and persons who are trained to help train the families in the community. I think it needs to come to that point and not just a standalone health fair, because people like to go health fairs, get free stuff. You will tell me if my pressure up or my sugar up or whatever, but then I leave and I go back to my community and I drink my soda and I eat my KFC. But if you come into my community in the health center and I come and I know it have a cooking class, and I may not go, but my friends say, I went to cooking class last week, it was really good. I'm encouraged to go. It's right there in my community. And I think that could spur on changes, both for prevention as well as management of persons who are already ill.
Thank you so much, gentleman in green, and then the gentleman in front. Thank you for your patience, sir.
Good night.
Good evening.
I have something here that I think you need to hear. It's not from me, it's from a patient.
Is someone speaking? We're not hearing it at all.
In that case, I'll tell you what he said.
Yeah, you can. Go ahead.
Okay. This is his voice from the 1st of October, 2012. He was at San Fernando General Hospital at about 10 o'clock in the night when no family members were around. He was assaulted.
Could you just speak up a bit, please, so we can hear you clearly?
He was assaulted. Assaulted.
On the hospital compound?
In the ward. Somebody just asked me by who. We never had a way to identify who was there at that time of the night. In this recording, he's telling me that the person who comes to change the bed sheets and take out the bedpan so that he could not help himself. They bounced his swollen, aching feet on the wall of the building, which is opposite Harris Promenade. So this is the men's ward. They left him in distress. They struck him, they stomped on him. And that was on September 30th, 2012. When I came the next day, October 1st, I made that recording. Dad would usually write everything down. He didn't write this down. So we tried to find out from other staff around who was there, who was working on the ward at that time during that shift. They told us that someone might have come in from outside to make up the numbers because they had staff shortages. So my recommendation, could you just slip something in that you change the apparel that the bedpan people might show up in to do their job? Maybe you could introduce numbering, something conspicuous that we could identify them, because we had to do nothing. You know, you can't have cameras.
Did they eventually find out who assaulted the person?
We never did.
And what is the outcome of the person? Was he discharged eventually, or she discharged?
On October 20th, Dad died.
That must have been harrowing. Is there a particular recommendation you have where that is concerned? That sort of situation?
Well, that was my recommendation about the apparel, making the staff more conspicuous, more noticeable, more identifiable.
Okay.
Okay. I have other things to say, but not right now.
Well, we have 12 minutes left, so you need to say what you want to say now, because we're running out of time. If you could be as concise as possible, we literally have 12 minutes left.
Okay. Non-communicable diseases, bad eating choices. Oh yes, there's one thing I forgot to say before I talk about the food. Empathy. I listened to everybody here. Some of the stories are really awful. Perhaps you could suggest that the training of your medical workers would incorporate something called virtual reality or immersive virtual reality, where you could give a first-person perspective to your future medical workers. So you're simulating.
I don't think the issue is training in. What I think is that the issue is monitoring and quality control and response to shortcomings. I think they're trained, but if no one is monitoring and there are no consequences to treating patients poorly, it continues. I don't think it's training at all. I think it's management of it.
Now I could talk about the food aspect. Have you tried finding out from some of these fast food franchises if they have ever experimented with the condiments? Everybody seems to always get ketchup, pepper.
Well, to be fair, that's not our remit as a committee. That's their business. We're not getting into them running their businesses.
Okay.
It has to do with NCDs and the health of the nation.
All right. What next?
If you could kind of wrap up so we could take the 2-3 people left
Yes.
at the time, please.
I'll wrap up. Thanks.
Thank you so much. We have a gentleman in front here and then the lady in the back in the printed out top.
Hello, everyone. Thank you. I'm an international volunteer. I came to volunteer with the Geriatric Society. One thing I wanted to bring up is back to the NCDs. One particular one is mental illness, and I really want to talk about stress, including anxiety and depression. So I'm a student. I graduated with a biology degree and a music degree. I'm also a music major, and don't worry, I'm not going to sing. Don't worry about that. But one thing I've noticed is the impact that art had on managing so much stress. When I grew up, drugs, when he mentioned that people pick up a cigarette at the age of as early as 17, and Dr. Richards said, if we're surprised, even I wasn't surprised, because I've seen that you walk into a bathroom and there are people smoking in the school, in high school or in secondary school, no less. And one thing you notice is anyone that's involved in music and the arts never touch one of these drugs. And why is that? It's because they have an outlet for stress. They have an outlet. Many students face so much stressors throughout their entire life.
I think Bob Marley might disagree with that.
That's true, but what the point I'm making is what we need to do in our schools is to encourage a positive outlet for stressors that making sure that students don't pick up a cigarette when they're stressed out, and instead encourage them to join something that's more positive. And what example I'm bringing is music. I think that was such a positive part of my life that helped me control so much stress. And it's just something that when you really think about it, I mean, it's a very positive thing because it shares an artistic expression. It's not just for entertainment. Earlier, we saw videos of some students. They're being interviewed, and they were making art based on their mental anxieties and mental states, and that was an outlet for them. Not only are they sharing and exposing those outlooks to us, to the public, but they are also able to express their own emotions, not through speech and not through public speaking, but through something that they feel the most comfortable expressing it in. And that's really the point I want to make. I think in schools and all over the world is we need to encourage a more positive outlet, a creative outlet for people to engage with. So they can increase their confidence to come up, and especially men, to come up and be vulnerable to the outside world and seek help.
Thank you so much. I think your comment is in alignment with what many have said earlier on in terms of having a multi-dimensional approach to dealing with the issues. It's not just one approach alone. It's because human beings are multi-dimensional in nature. The lady, yes, please.
Good afternoon, ladies and gentlemen.
Hi, good evening.
My name is Stephanie Modest. One of the points I want to make is that I find that eating the home, for you to eat properly, start from home, not the school. The school comes second. Once the parents feed the child the proper food, it starts from home. That is where I started from. Right? From my grandmother teaching me to read properly and giving me all this at a bush. Start from there. Right? The ministry, as I said, charity begins at home and then abroad. So that is where it starts. And another thing, appointments for the hospital is be too long. I guess everybody come and talk about that. Right? The biopsy. My husband had also got a biopsy. And that biopsy, he had also get his own needle. You have to go out there and buy these things to bring it back into the hospital for them to do the biopsy, right? Another relative of mine, she went to the hospital with multiple, what does she have again? Well, okay, multiple sclerosis, a lot of those things. And they simply put a cry down to the end of the year. Now,
She's in pain every single day. It's every day I have to go down on my knees and pray, asking God so that, to help her. I find if somebody in pain and you realize that it has so much, they could have speed up that time. Don't put her so far, right? So that is my contribution.
Thank you. In the last, is there anyone else who wants to make a comment? We have time for just 2 more quick comments, yes, sir. And then the lady at the front, and we'll have to wrap it to that. Go ahead, please, ma'am. Oh, sir, sorry.
Hi, good night, everybody.
Good night.
My name is Gail Morris, a healthcare provider and a member of the Diabetes Association of Trinidad and Tobago. Now, we talk about the medical records. 2019, I did a surgery in Port of Spain General Hospital. And the first surgery didn't work, and I had to go back twice to do it over a week and a part and thing. Anyway, the second part of my surgery and third part, no files for it. When I talking to the doctor about the surgery, according to health, if it is not written, it is not done. So if they did not see it in the file, I didn't have those surgeries. I asked for a copy of my file. I got a man file in my file. And then and they never find the remainder of my surgeries, which is not good enough. Thank you very much.
Thank you. Dr. Hamid, can people ask for a copy of their file? Is that their right? Yes. It's their right. So,
yes, it is the patient bill of charter.
Please. And then, yeah. I don't, the file thing in the digital age confuses me. I just can't wrap my mind around it. And it's a paper file I'm presuming people talking about, right? It's a hard copy file. It's not digital. Thank you. Yes, ma'am.
Good evening, everyone. My name is Dr. Lavanya Tondavada.
Could you just go a little closer and speak up, please? Thank you.
Dr. Lavanya Tondavada from Geriatric Society of Trinidad and Tobago. I want to bring up only 2 points here. We have to do the assessments. Over 65 age group need a comprehensive geriatric assessments in a regular basis. It's not like a 5 months or 6 months. We have to bring up that. Every 3 months, we have to assess. In that assessment, we have to do like a 5 M's. It's a multidisciplinary team has to involve. The psychologists, dietitians, physiotherapists, everybody has to come up like a team to assess that 5 M's. What is that 5 M's here? Mind, mobility, multi-complexity. What matters the most? And medication. We have to revise the medication because a lot of them taking unnecessarily medication for a lot of reasons. And most of the medications have a side effects too. We have to revise the medication while we're doing the geriatric assessments. We have to bring up that assessments both in a primary care and institutional level too. Thank you.
Thank you. And final comment?
Good night. My name is Carrie Edgel. I'm a practicing radiographer and sonographer. I'm here representing the Radiographers Board, but as my colleague said, the comments that I have is not on behalf of. Just to touch on what the lady just said, I believe that we need to move away from giving medication to chronic diseases because I have seen in my profession the deterioration of the kidneys as a result of long-term use of these medications that they use for the chronic diseases. And so now we have a problem of providing dialysis for the patients that we gave chronic diseases tablets for. So it's like we're creating another problem trying to solve the first problem. So we need to revise the plan that we have because some of these patients join the lifestyle clinics very early. So we can, as my colleague said, try to teach them different ways to feed themselves, how to prepare their meals, teach them to exercise and consume more water and so on, so that we would move away from having long-term use of medication, because it really does destroy the kidneys. The other thing I wanted to touch on was the medical record, and I think we need to have legislation in this country done to turn our systems to accommodate digital filing. Because as it is right now, we are in the RHAs having large storage of hard files. But when patients ask to access these hard files that are from years gone by, it's very difficult to access them because they may have deteriorated because of the storage capacity of having lots of them in small places and not stored under the right conditions. So they deteriorate quickly. If we were to convert them into soft copy, it will be easier for us now to transition to access them when patients had surgeries before, so that you can provide some sort of information that will be valid. That's my contribution.
Thank you. Thank you so much. And I'd like to take time to thank you all for making the time to come here today. We really appreciate you taking the time to come here and share your stories. Your stories are all acknowledged and valuable and noted. We have been taking notes. This is of course being broadcast live and recorded so that the Secretariat to the committee can take your feedback into our deliberations before the final report is made. A lot of what you have said, we have heard in Port of Spain and we've heard in San Fernando. So it is not unique to Central Trinidad, unfortunately. And the issues are the issues with availability of medication, the system to get your prescription filled clearly needs a lot of work. The issue of the interface between medical healthcare professionals, be it nurses, some doctors, the issue of long wait times. To me, one of the major issues is an understanding of what can be resolved at the healthcare centers so that people know what they can go to the healthcare centers for and get an hour turnaround as opposed to going to the general hospitals and waiting 12 hours. I had a 12-hour situation with my mother myself. 12 hours, checked in at 1:45 and didn't leave until 1:45 the next morning. But I will tell you the intake was fantastic, the initial screening, but the wait to see a doctor after that took 12 hours and she was in distress. But I will also say the good part is when she was warded, her health care was excellent. I don't know if it's because it was me, but I spoke to other patients on the ward and they also had good reports. But they also complained about the long wait to get health care. And of course, that atrocious pharmacy issue that almost everyone spoke about, which clearly needs some work, no matter what people tell me. No one should be waiting after having gone through the trauma in some instances of getting your diagnosis, waiting another 4 hours to get a prescription filled, and going to different locations to get a prescription filled cannot be efficient or humane. So we take all your comments very seriously as a committee. And again, I want to thank you all for coming here and giving and sharing your story, because medical information is private information and you all have been very, very candid in doing so. I'd also like to thank the members of the committee for their support and coming, agreeing to come on these interfaces, because we think coming to you is very important. We can't sit in Parliament there and not come to you because the Parliament belongs to you, the people of Trinidad and Tobago. That the Parliament should serve you. So we know it's important to come out to you. We'd also like to thank the NGOs who came out here today, and of course, Dr. Abdul Hamid for his presentation. We'd like to thank all who assisted the stakeholders in logistically putting this thing together, Ms. Rena Pancham and the team at Centrepoint Mall, the North Central Regional Health Authority, the National Library and Information Services Authority, NALIS, the National Information and Communication Technology, iGov, TT, and YTEP, and of course the office and staff of the Parliament for their continued support to this committee, and of course for making these interfaces very, very important, because they are the people who put this together. We just turn up now and interface with you, but they really do the hard work behind the scenes, the technical staff, the AV people and all of that. So again, thank you all. And we'd like to inform our audience that our next town hall meeting will be coming to Arima. So we've covered Port of Spain, San Fernando, now Central. And the next one is scheduled for April 25th, in the borough of Arima. We invite all who reside in East and anywhere else in Trinidad and Tobago to attend and have your say and give us the feedback. Our town hall meeting is now adjourned, and thank you all for being here. Those comments are really atrocious.